So Megan is from Mass General Hospital. She specializes in treating melanoma, particular interest in the adjuvant and neoadjuvant setting. Also does a lot of work in therapies for patients whose disease has progressed after immunotherapy and novel therapies, and also treating immune side effects from those therapies. So with that, I'm going to invite up Megan. Thank you.
All right, good morning, everyone. And I echo Dr. Bookbinder's comments. So excited to be here with you guys today. And I have the pleasure of being able to talk about this really interesting and evolving space, which is how can we best treat early stage melanoma? And our objectives are really focused on that. And I think most of the talk will be focused on cutaneous melanoma, melanoma that arises in the skin, and some of the advancements that we've seen in the treatment of resectable disease. Specifically, this kind of adjuvant therapy, that therapy after or therapy after surgery, neoadjuvant therapy, systemic medication given before surgery, and then this perioperative approach, which is somewhat like a sandwich approach, medications given before and after surgery, all with the goal of reducing the risk of the melanoma coming back. As Dr. Bookbinder was saying, we've really seen an evolution in how we treat melanoma really just over the past 10 years. And it's pretty impressive to think about where we've come and now where we're going. And this is just a slide showing approvals for immunotherapy alone. So many of the talks you'll hear about today, some of these are more burgeoning areas that we don't have approvals quite yet. But where we see approvals is pretty plentiful, really, if you think about advancements just over the last 5 to 10 years. First, in the unresectable space, with ipilimumab, a CTLA-4 inhibitor back in 2011, followed by the PD-1 inhibitors, pembrolizumab and nivolumab. And since that time, some combination approaches. And with the improvements that we've seen in the treatment of metastatic melanoma with these drugs, they've shifted to earlier stage disease. Again, all with the goal of saying, can we use some of our best medications first to improve the likelihood of cure? First with high-dose ipilimumab in 2015, followed thereafter by approvals for drugs like pembrolizumab and nivolumab for stage 2 BC melanoma, stage 3 melanoma, and resected stage 4 melanoma. So who are we really talking about when we're thinking about using these medications before and after surgery? And to help understand that, I'm just going to briefly go through the staging system. So melanoma is staged like other solid tumors, stage 1 to stage 4. A stage 1 melanoma is a melanoma that's thin, relegated to kind of the skin and the soft tissue around it. Stage 2 melanoma is a melanoma that is a bit thicker. It may or may not have what's called ulceration, meaning is that top layer disrupted, or is it nice and smooth when the pathologists look at it under the microscope? A stage 3 melanoma is often a melanoma of any thickness, but has evidence of spread to nearby lymph nodes. And that can either be microscopic spread, meaning that when our surgeon like Dr. Cohen takes the patient for a sentinel lymph node biopsy, the pathologist sees microscopic cells in that sample, or what's called macroscopic spread, meaning evidence of melanoma spread that we can either see on a scan or feel on exam. And then stage 4 is that we see melanoma start in the skin with evidence of distant spread elsewhere. And this pie chart breaks down what we consider the incidence of melanoma. So for the patients that we're really focused on, these stage 2, stage 3, intermediate, that makes up about a quarter of the patients that we know are diagnosed each year. So again, we're thinking about adjuvant therapy, therapy after surgery. It's primarily focused on patients who have those thicker stage 2 melanomas or stage 3 melanomas, which encompass spread to those nearby lymph nodes, but again, in a microscopic fashion. So when we think about a patient's journey who may be counseled on these approaches, again, we know that first and foremost, surgery is the treatment of choice. And we're able to get good information about the melanoma through that wide local excision or the sentinel lymph node biopsy. And we know that for the majority of patients, they are cured by this therapy alone. But despite excellent surgery, we understand there is a risk of recurrence. And that's really where these medications come in. Can we use drugs after surgery to reduce that recurrence risk and hopefully improve the likelihood of cure? And the rationale for that is just the concern that even again, after a thorough surgery, potentially a lymph node evaluation, there could be microscopic cells that are left behind. And that's where the use of these drugs really comes into play. And this schematic here showcases the rationale for adjuvant immunotherapy. So you can see the surgeon removes the primary tumor, but in the event that there are microscopic cells left behind, we give these medicines to boost the immune system, to recognize those microscopic cells, hopefully rid them from the body, and improve the likelihood of cure. And we have approvals for a couple different treatments that target what's called BRAF, which we'll explain, and again, these immunotherapy agents. So BRAF, so what exactly is it? And that way we can understand why these drugs may be helpful. So 50% of melanomas that arise in the skin possess what's called an activating BRAF mutation. So you can see what looks like normal cell signaling on the left and then abnormal cell signaling on the right. And normally when a cell is growing and dividing, it gets a signal from above, it does the job it's supposed to do, and once that job is complete, that signal turns off. But when BRAF is mutated, and this is a sporadic event, it's not hereditary, we don't quite understand why it happens, but we know when it happens, it's implicit in that cell growing and dividing improperly. And when cells are growing and dividing improperly and never get that switch to turn off, that can lead to the development of a tumor. And very smart scientists realized, well, if this is the reason that these cells are growing and dividing badly in the first place, let's try to shut that lid switch off. And that's what these medications are attempting to do. So medications like dabrafenib, which target BRAF, and then trametinib, which target that protein right below it, MEK, have shown improvement when we've used them in the treatment of BRAF mutated melanoma. We've seen improvements in the stage 4 setting when we've used these drugs. And then in 2018, we saw improvement in the stage 3 setting. So this was what's called a study scheme or design that looked at how did these drugs do in comparison to placebo, meaning surveillance, which we did for the majority of patients back in 2018 after discussion. So it looked at patients with stage 3 melanoma with one of these activating BRAF mutations, and patients were randomized 1-to-1, meaning 50% got the medications, 50% were monitored, and treatment was continued for a year. And they're really trying to understand how did these drugs do in reducing that risk of recurrence. And we've now had the benefit of time to see that, yes, even when those results were first published and presented, we saw benefit. And now 5 years later, we see the 5-year what's called recurrence-free survival, how long patients are living without any evidence of that melanoma coming back, favoring the dabrafenib trametinib group, 52% versus 36%. So this is an approved therapy that we have and we discuss with our patients. In addition, we know that we have the ability to use medications that target the immune system, like I referenced. So these drugs work completely differently. They're really trying to work to activate our body's own, in a sense, army to stimulate itself, go out and see those cancer cells for what they are and kill them. So the T cell is somewhat like the soldier of the immune system. When that T cell is activated, it can go after things in the body that don't belong, like bacteria, viruses, and in this case, cancer cells. And we know that there are receptors on that T cell surface that can activate it, and then there are receptors on that T cell surface that can inhibit it. And a lot of what we're focused on, both now with medications that we use and medications that are under development, is how do we help activate that T cell, and then how do we help block signals that may inhibit the T cell. And one of those is the PD-1 blockade, those drugs like pembrolizumab and nivolumab. So we know that a cancer cell can actually express this PD-L1 on its surface, and when it binds to the T cell, it can effectively shut it down. So if we block that, our goal is to activate the T cell, see the cancer cell for what it is, and then ideally eliminate it. And I'll only show a couple slides on some of the trials that we've seen in this space, but across the board, we've seen benefit in stage 3 and resectable stage 2. And Checkmate 283 looked at the role of, well, how does nivolumab, that PD-1 inhibitor, work against ipilimumab in patients with stage 3 or resectable stage 4 melanoma? And then Keynote 054 looked at a similar patient population, though stage 3 alone, and looked at the drug pembrolizumab, and this was versus placebo. And the long and short of these figures is very similar to the targeted agents. These drugs did show improvement in that recurrence free survival with reduction in risk when we're thinking about treatment of, again, earlier stage disease. So I think a major question is, why don't we just give these drugs to everyone? We've seen that they reduce the risk of recurrence, but I think the challenge is we really have to be thoughtful about that risk benefit. Like I mentioned, some patients are cured with our exceptional surgeries alone that are performed by our surgical colleagues. And unfortunately, we realize too that these drugs are not perfect. They don't reduce the risk down to zero. So some patients may receive these drugs, but still have a melanoma recurrence. And right now in the clinic, we're not armed with the ability to identify which person falls in each bucket. And we're always very mindful, again, though we would love to decrease the risk as much as we can, these drugs do come with some limitations. One, it's a year of therapy. That's time, that's potential financial toxicity, and there are real risks of side effects. And though I won't have time to really delve too deep, I think one thing I'll mention is these immunotherapy drugs, again, work very differently. They're working to boost our body's own immune system. So in about 10 to 15%, the immune system, in a sense, can lose its way, become dysregulated, and cause inflammation in normal parts of the body. And when that occurs, simply stopping the drug is not a fix. We often have to use medications to help suppress the immune system. And in rare cases, these can be chronic side effects. So again, we really put those into our calculus when we're helping to counsel patients and their families about the best choice. But with that being said, we are now lucky to know that we have several approvals in this adjuvant space after surgery. And this figure and tables just really breaks down kind of what approvals we have at each stage, understanding that, yes, we can think about immunotherapy for stage 2B, C, 3, and even resectable stage 4, and then those BRAF targeted therapies in resected stage 3. And I think one area that's garnered a lot of buzz, rightfully so, is this personalized cancer vaccine that many in the audience, I imagine, may have heard about, as it was not only publicized in the academic press, but we saw a lot of interest kind of across the lay press as well. And this is basically a schematic to help understand kind of what is this personalized cancer vaccine? Because what we're trying to do is really trying to hone our therapies the best we can to the person in front of us. And this technology is really attempting to do just that. It's taking a patient's individual tumor and looking at the DNA of that tumor itself and trying to understand what mutations are present that may be kind of, again, the lock and key of why the cell is growing and dividing improperly in the first place. And again, very smart, sophisticated science has allowed us to actually target those unique mutations in the tumor itself, a term sometimes called neoantigens, and then formulate a vaccine. And a study looked at this approach in combination with pembrolizumab. So that drug I had referenced is already an approved regimen after surgery. And it looked at patients with a higher risk melanoma stage 3B, C, and D. And 50% of the group got the vaccine plus pembrolizumab, and 50% of the group got the pembrolizumab alone. And we did see improvement in what's called that reduction in recurrence risk. So this is an area that I think we're all very excited about. Can we personalize treatment? Can we see improvement? And notably, this was without significant increase in toxicity. So next steps are a larger study looking at this approach, as well as expanding this to other tumor types. So now what about neoadjuvant therapy? So this is that treatment where we use these drugs before surgery. So why would we do that? We've shown that these drugs can work after, but I think biologically, we're all excited that if we use these drugs before, we might actually stimulate the immune system more effectively. And you can imagine if we're giving a drug through an IV to stimulate the immune system, if that tumor is still in place, it gives the immune system something to recognize. So activation has the potential to be improved. And through what's called kind of preclinical or studies that are done in the lab, we've seen that when we give these medications before, the immune system gets activated more effectively. More T cells and what are called more diverse T cells. So not only can we potentially see shrinkage of the tumor, but we can see, hopefully, and some of the data that I'll show, eradication of those micro metastatic cells more effectively than when we use the adjuvant therapy alone. And this slide, again, just highlights the potential benefit, more effective activation, potentially tumor shrinkage. It gives us an earlier kind of readout of the objective response. And from a research standpoint, really tries to help us understand mechanisms upon which medications might work really well, making a tumor sensitive, or if it doesn't work so well, resistant. So when we think about the patient's journey who might be eligible or who we might consider a neoadjuvant therapy, it's really a melanoma where we have what's called those macroscopic lymph node involvement, lymph nodes that we might be able to see or feel on exam. And medications are given before, patients are taken to surgery with the potential to have additional medications after, of course, with close surveillance. And how do we determine if these work? Well, first and foremost, we still use our tried and true scans. Here we can see CT scans. I've circled what's called an axillary lymph node, a lymph node under the armpit for someone who received medications before surgery. So when they were first diagnosed, kind of a bulkier lymph node, and then after 3 cycles of therapy, a much smaller lymph node. And then we also have to lean heavily on our pathology colleagues. So when a lymph node or a group of lymph nodes are removed, they look at these under the microscope for us and tell us, well, what do they see? And they're able to break it down by how many cells they see that are related to cancer under the microscope versus treatment effect, things that look like more necrosis or inflammation. And they can break it down by either they see no cancer cells, a complete response, a near complete response, which is less than 10% cancer cells, and then less than 50%, which is a partial response. And then in the case of limited response, we see more than 50%. And we use these, as I'll talk about, to really try to personalize an approach. In the next few slides, I don't want you to worry too much about these designs or schemas, but more just trying to help you understand. People are working really hard to understand how much therapy do people need. Can we tailor things according to the person in front of us? And this study, which is called Opposite Neo, was a dose finding study. Could we find a sweet spot when we're using the combination of immunotherapy drugs, ipilimumab and nivolumab, just before surgery? So this was the plan, just to give the medications preoperatively with no prescriptive therapy after surgery. And what they found is there seemed to be a sweet spot with respect to the dosing of the ipilimumab at kind of a lower dose of 1 milligram, the nivolumab at a standard dose with respect to the effectiveness, but also trying to minimize the toxicity that someone may experience. And I think the long and short is that people did well when we gave this approach kind of across the board. But we saw that when there was that pathologic response, meaning the pathologist looked at it under the microscope and they really didn't see many tumor cells, we saw kind of slam dunk responses with 96 or higher percent of patients not experiencing a recurrence. But if we did see more than 50%, we realized, well, maybe those patients would benefit from more. And that's what this study was really trying to also tease out. Can we personalize each patient's journey? So looking at a similar patient population with the idea of something that could be macroscopically seen or felt, got the dose of ipi/nivo that they had found to be effective, but then they really tailored it based on how did the surgical sample look under the microscope. And instead of every patient getting what's called a total lymph node dissection, where all the lymph nodes are removed, they removed just the dominant lymph node and looked at that response under the microscope and said, okay, if someone's tumor responded well, perhaps we can omit more surgery, we can omit more therapy after. But if we saw a tumor didn't respond as well, well, then we know that escalation might be better, a bigger surgery or perhaps medications after. And again, the key points from this was, again, very encouraging results when we used this therapy before, when we looked across patients, but the best response we're seeing in patients who had that pathologic response. And we knew that when we looked at, well, for the people who fell into that non-responder category, it did seem that more could be beneficial in respect to more surgery and more therapy after. Treatment was overall well tolerated, and like Dr. Cohen will talk about, being able to omit that total lymph node dissection certainly improved surgical outcomes for patients with respect to adverse events and quality of life. And kind of lastly, this is one of the newest studies. It's kind of shaping the way too that we're treating patients in the clinic that helped us really tease out, well, what's potentially better? Is neoadjuvant really better than adjuvant? And in this study, they were trying to help us understand it. So looked at more advanced stage 3 and resectable stage 4 cases of melanoma. And patients were randomized either to surgery up front, followed by that adjuvant therapy, or the sandwich approach of therapy with pembrolizumab, that PD-1 inhibitor, surgery, and then the potential to complete 1 year of therapy afterwards. And they were looking again to see how did patients do. And we saw that the group that got the neoadjuvant therapy before did seem to fare better in respect to what's called event-free survival, in terms of being able to have the surgery was still very feasible, and that risk reduction. So where do I see these going? I think we know we have great data so far, but we want to build on it. We want to look for new neoadjuvant regimens, which many are underway in clinical trials. This is just a schema that looks at the amivo-rela combination. And then I think importantly, personalizing treatment, both with respect to escalating or de-escalating therapy, like I talked about, and try to find biomarkers to help us better counsel patients about the risks and benefits of moving forward. And I'll end with just a clinical case, just to showcase that we're using this in the clinic. We're seeing effect. This was the same CT scans that I had shown before. This was a gentleman who had a stage 2 melanoma. Initially said, you know what, immunotherapy is not for me because of some other medical issues. Ended up having a recurrence in a palpable right inguinal or right axillary node, which you can see here. We gave 3 cycles of the pembrolizumab. We saw shrinkage on exam, shrinkage on scan. And we saw from our pathology colleagues that this was consistent with a complete pathologic response. This is a patient I share with Dr. Cohen. I also share this patient with Dr. Cohen. This was the melanoma of unknown primary that developed a palpable inguinal lymph node, a lymph node in the groin. This patient was treated on a clinical study, had 3 cycles of therapy. We saw some shrinkage on exam, some shrinkage on imaging, which I've highlighted here. And again, a complete pathologic response. So a lot to be encouraged by. And I think in conclusion, we know that these medications can improve outcomes. We want to be incredibly thoughtful about the way we talk to patients and their families about the pros and cons, particularly in the adjuvant setting. And I think we have a lot to be excited about with respect to future therapies to come. And I thank you guys all for your time.